everyone. I'm Lisa Prosser and the director of the Susan B. Meister Child Health Evaluation and Research Center in the Department of Pediatrics. I'm really delighted to welcome everyone to our lecture today, which is the 14th in this series, and especially grateful for the opportunity to host this event after a 2-year hiatus due to the pandemic. I'd also like to extend a very special welcome to our keynote speaker, Terry Fulmer, the president of the John A. Hartford Foundation, and our 3 panelists, Deborah Cha, Todd Herrincole, and Preeti Malani, whom I'll introduce in just a few moments. Before turning the program over to our speakers, I have a few opening remarks. I'd like to start by recognizing an individual who is instrumental in the development and evolution of this lecture series, and also to announce the recipients of our Best Paper Award in Child Health Policy. First, I'd like to acknowledge Dr. Susan Meister and her vision in supporting this lecture series and our center. This lecture event is named in honor of Dr. Meister, an accomplished child health policy researcher herself. She recognized the promise of creating an interdisciplinary center for child health services research and policy at Michigan. And for the past 25 years, she has provided crucial support and partnership in helping to develop our center since its very beginning. Her inspiring commitment to multidisciplinary research is what has launched this very special event. Our center sponsors this lecture each year, aiming to engage an interdisciplinary audience in a conversation about pressing issues that call for an interdisciplinary response. I'd like to take a moment to recognize Dr. Meister and her valued role. If we were in person, I would ask her to please stand, but today I'll just have to extend my gratitude for her support virtually. Thank you very much, Dr. Meister. Next, I'd like to announce our paper award winners. This prize has been established to recognize an outstanding scientific paper in child health policy by a trainee at the University of Michigan. Nominations are evaluated with respect to the contribution of novel methods or expanding knowledge base about a significant clinical or public health issue. The quality of the research and importance of policy implications are also considered. Today, I'm pleased to announce the 2021 and 2022 recipients of the Best Paper in Child Health Policy. Our first award recipient is Dr. Anita Masters. Dr. Masters' paper evaluated Michigan's 2015 administrative rule change on vaccination policy. Her geospatial analysis used novel methods to showcase the spatial heterogeneity of immunity in Michigan. She received her PhD in epidemiologic science from the School of Public Health, and currently Dr. Masters serves as Epidemic Intelligence Service Officer at the CDC. Congratulations, Dr. Masters, and thank you very much for joining today. Our next award winner is Dr. Sarah Abelson, and her paper focused on Muslim young adult mental health and the 2016 US presidential election. This paper addresses the important issue of how social and political events affect the mental health of populations subject to discriminatory policy changes and the associated social and political climate. The paper was described as innovative, methodologically sound, and highly relevant to health and social policy. Dr. Abelson recently received her PhD in health behavior and health education from the School of Public Health. And currently she is Senior Director at the Hope Center for College, Community, and Justice. Dr. Abelson was unable to join us today because she just had a child on Sunday. And so congratulations to her on all of these accomplishments. Our next award winner is Dr. Josephine Granner, whose paper, Predictors of Parenting Stress for New Fathers Point Towards Trauma-Specific Perinatal Interventions, addresses a significant public health issue: the intergenerational transmission of child maltreatment and psychiatric vulnerability via fathers. It examines relationships between new fathers' history of child maltreatment trauma and their mental health and parenting stress during the transition to parenthood. Dr. Granner recently received her PhD from the School of Nursing, and she'll be joining the National Clinician Scholars Program at Yale University this fall. Congratulations, Dr. Granner. And congratulations to all of our paper award winners for all of your work in advancing the field of child health policy. As we move into the formal program, I'd now like to take a moment to comment on the interdisciplinary focus of this event. A key goal of this lecture series is to bring people together from across the institution and the broader community to discuss issues in child health policy that cross disciplinary boundaries. Our topic today, the effects of the pandemic on trauma and abuse within families and communities, brings together attendees from a vast range of backgrounds, with students, faculty, and alumni from across schools and units here at the University of Michigan, as well as from the broader community. A warm welcome to everyone for joining today, and thank you for joining this conversation. Today's theme is of great importance as we are just beginning to learn about the effects of the pandemic on many things, including trauma and abuse, and to consider longer-term effects as well as interventions as more data emerge. We have an incredible panel of speakers today, each providing their own unique perspective on trauma in families and communities and across the lifespan. And we look forward to a lively discussion. The format for the lecture event today will begin with a presentation from our keynote speaker, Dr. Fulmer, followed by remarks from our three panelists, and then followed by an open Q&A. We also have a number of questions that were submitted prior to the lecture event today. We'll be drawing from those questions as well. Next, I am delighted to introduce our keynote speaker. Dr. Terry Fulmer is the president of the John A. Hartford Foundation in New York City, a foundation dedicated to improving the care of older adults. Established in 1929, the foundation has a current endowment of more than $500 million. She serves as the chief strategist for the foundation, and her vision for better care of older adults is catalyzing the age-friendly health system social movement. She is an elected member of the National Academy of Medicine, served on the Independent Coronavirus Commission for Safety and Quality in Nursing Homes, established to advise the Centers for Medicare and Medicaid Services. She previously served as Distinguished Professor and Dean of Health Sciences at Northeastern University. Prior to that, she served as the Early Perkins McGriff Professor and founding dean of the NYU College of Nursing. She received her bachelor's degree from Skidmore College, her master's and doctoral degrees from Boston College, and her geriatric nurse practitioner postmaster's certificate from NYU. She completed a Brooktail National Fellowship, and she is the first nurse to have served on the board of the American Geriatric Society. She's also the first nurse to have served as president of the Gerontological Society of America, which awarded her the 2019 Donald P. Kent Award for exemplifying the highest standards for professional leadership in the field of aging. These just are a few of the many accomplishments and accolades for Dr. Fulmer, too many to present here today. Dr. Fulmer is internationally recognized as a leader in her field of healthy aging. She has led and inspired enormously important efforts in the interdisciplinary science, policy, and service that are needed to advance healthy aging. And her portfolio of work, her strategic planning, and her leadership in creating new frameworks to facilitate the infusion of evidence-based best practices into nursing care for older adults can inform our efforts in child health. Her pioneering work on elder abuse and neglect provides insights for considering these topics in the context of children. We're very fortunate to welcome her here to Michigan today. And Dr. Fulmer, thank you again, and I'll turn the podium over to you at this point.
Thank you so much for that warm introduction, Lisa. And I am very honored to be with all of you at the University of Michigan and beyond. Susan Meister is a dear friend. We've known each other for many years, and she is a true champion for the health and well-being of children. And as she invited me today, I thought, what might I say to engage all of you in the issues related to older adults? And so to begin with, I'm going to start very granular. The effects of the pandemic on trauma and abuse in families and communities. That's a powerful label for our meeting today. Well, during the pandemic, elder abuse doubled during the course of the pandemic. We heard themes in this country when the nursing homes were at enormous risk, beyond enormous risk, when they had no PPE, no equipment, no staff. We heard phrases like, well, we need to cull the herd or they were going to die anyway. I don't think that's the country that I recognize. We love longevity in this country. We love to be proud of the fact that we have doubled our lifespan since 1900. If you were born in 1900, you lived to be about 40. Today, you live to be about 80. So that's a miracle. But with that comes responsibility. So I'd like to frame that today. And as Susan and I discussed what I might share with you today, I will be focusing in on a very important white paper that became a publication in Health Affairs that we wrote for the new administration when the Biden administration was coming in, called Actualizing Better Health and Healthcare for Older Adults. And I'll talk about that from the perspective of the foundation. So thank you again for including me in this important conversation today. Next slide. Our foundation is a private philanthropy in New York City, established by the family owners of the A&P grocery store chain in 1929. And the mission was to do the greatest good for the greatest number. And in the early 1980s, our foundation made the very specific commitment to focus on better care for older adults and developing the workforce for that quality care. And that's where we sit to this moment. Next slide. We have 3 priority areas. So dedicated to improving the care of older adults, our priorities are creating age-friendly health systems. That means starting where at your kitchen table, getting you through the emergency room, to the ICU, to rehabilitation back home, and a system of care across each care setting, whether it's a homeless shelter, a prison, a nursing home, an ICU. Support for family caregivers. We have 40 million family caregivers in this country saying, for older adults, saying, what do I do now? We send people home after acute care, to rehab, to home with tube strips and drains, and family members who are at great risk of becoming neglectful or abusive because they are completely overwhelmed. We also have a priority area of improving serious illness and end-of-life care. Serious illness, that might be Alzheimer's disease. And we know that cognitive impairment and Alzheimer's disease put you at greater risk for abuse and neglect. So end-of-life care, very important to the well-being of all of us. Let me say that it goes without explaining that healthy aging begins at birth. And everything we do with children to nurture them, to teach them, to support them straight through their adulthood to their older age is a continuum of intergenerational care and intergenerational communities. Next slide. This is a Wordle that we did as we began our age-friendly health system work. We did it with Next Avenue. I like to say, and I just lost my screen, but I'll find it. There it is. I like to say that Next Avenue is AARP for hipsters. And what we did in this survey was ask people, what is age-friendly care? And this was really very early on. We started our age-friendly health system work in 2015, and by 2016, we're out of the gate. But this early survey said that older adults said age-friendly care means that you listen to me, that you ask me what I want, that you know me, you provide care, and you understand, respect, and help, and talk to me. These seem like pretty basic human rights for somebody looking for care. And so we're very, very passionate about addressing these phrases and these instructions from those respondents. Next slide. Planning for the future. So I worked at the Harvard Division on Aging when I first met Susan, and we had every slide that we began our speeches with said, there's going to be a lot of older people in this country. There's the graph. We've been showing that same graph since the 50s, but we have not prepared. So right now we have a demography of older adults growing and becoming more diverse. Very important to focus on the equity and inclusion and access for those people. Complexity. Older people have multiple chronic conditions, dementia, disabilities, social isolation, social determinants that have not gotten them to the path they might have preferred, and disproportionate harm. Older adults have higher rates of healthcare related harm, discoordination of care, poor preparation for disasters, and one need only look at Katrina or the floods in Florida, or the many ways in which older people are at risk during disasters, and certainly COVID. Next slide. So with the success of longevity comes new responsibilities. We know that older adults have unique care needs, and that we have about 7 million older adults in this country living with dementia, and that number will rise to 12 million by 2040. And about 40% have disability. Mobility related is the most common disability, and unmet social needs that have accumulated. Next slide. So I was invited to work with the National Academies of Science, Engineering, and Medicine in order to prepare for the Biden administration. And with these esteemed colleagues, Dave Rubin, John Arbach, Donna Fick, Colleen Galambos, and Kim Johnson, we wrote a paper on actualizing better health and healthcare for older adults. And I'd like to use that as a very high frame today. And I think all of us will see our work in this, but talking about what we can do now to make sure we actualize, not imagine or not hope, but actualize better health and healthcare for older adults. Next slide, please. So we know that it's so important to help provide direction to the administration when it comes to healthcare priorities. There are many. Next slide. So in this paper, we had 6 vital directions that we think are imperative to improve the lives and quality of life for older adults. And first, creating an adequately prepared workforce. In this country right now, the mantra is workforce, workforce, workforce across the age span, but certainly in geriatrics and in nursing homes in particular. Strengthening the role of public health. We have another project called Creating Age-Friendly Public Health Systems, but strengthening the role of public health, which really got gutted over the past 30 years, and all of us know that we need to bring back that vital system in our country. Remediating disparities and inequities, and we saw disproportionate harm and death in older adults who were non-Caucasian during the COVID crisis and beyond. And we need to develop new and innovative approaches to care delivery, allocate resources to palliative and end of life instead of our continuation of ICU care at all costs, and redesign long-term services and support. So some details I'd like to share. Next slide. So we need to work with HRSA, the Health Resources and Services Administration, and we're very proud of our relationship with that organization because they have really worked with us and partnered with us to infuse our age-friendly health systems 4M framework into their geriatric workforce enhancement programs. So we're in 43 programs, and everybody uses the same framework. What matters? Mentation, your mood and memory, medication, and mobility. What matters? Mentation, medication, mobility. We're using this in acute care, in nursing homes, in community care, in CVS minute clinics, and in our workforce training, so that we can have a shared language and create education and training that with simulation and virtual learning that brings this to fruition. Next slide. Our age-friendly public health system work has created conditions at national, state, and community levels that older adults need to live safely, healthfully, and productively. And we've prioritized targeted data collection and analysis to adapt existing programs, including that all-important emergency preparedness. And finally, what we are thinking about is how to mobilize Congress and to fund the CDC and state and local health agencies, so very much needed. Next slide. Remediating disparities and inequities, we've seen a great deal on this, but I'll be more impressed when I see the actions and the outcomes that happen when we think about how to implement programs such as criminal justice reform, facilitate meaningful partnerships with communities and organizations that serve people of color. One need only have looked at the horrifying events in Buffalo. At that Tops grocery store was there because it was previously a food desert in that area. They went to serve that community, and the violence that has ensued just reminds us how much work we have to do in this country, the murders that occurred. So reducing isolation, using the development of innovative housing options, recreational and employment opportunities, improving transportation and public safety measures for older adults. Next slide. We have to develop new approaches to care delivery. Technology must be adapted to the needs of older adults. They welcome it, they need it. Advances in telehealth and technology should be promoted through regulation, payment, and incentives. And technology can improve workflow in nursing homes and other settings and allow the workforce to focus on tasks that require human touch. Why do people move trays and move linens and do all those things that we could automate? We need to work smarter. Next slide. Need to allocate resources to palliative. Most older adults have not taken steps to plan for serious illness end of life, resulting in high burden of physical and psychological distress. Expanded access to palliative care is needed to improve outcomes for people with serious illness, especially those with poor access. All frontline clinicians need adequate training in primary palliative care skills, and we need to mitigate the fragmented care using established transitional care approaches that can improve serious illness and end-of-life care. Next slide. Redesigning long-term care services. Now, we wrote these slides and rewrote this paper before COVID. And most recently, on April 6th, our foundation was one of the major supporters for a new National Academy's report on improving the quality and safety of care in nursing homes, which we intend to make part of every social policy initiative going forward. We just cannot continue the way that we are conducting work in nursing homes. They're inefficient, ineffective, unsustainable is what that report said. Redesigning and making sure that all of you take a look at that front matter from that report so that you can help us think about how to make sure that we have community-based long-term care services. People want to be home. We need to help them stay home, and we need comprehensive systems of care. Next slide. So the underlying issue in this country is ageism. And yesterday I saw in the New York Times a piece that talked about the fact that we are tipping too far to being the word was gerontocracy, meaning that we take better care of older adults than we do younger people. May I simply say that we need to take care of everybody. It's not a zero-sum game. It's not okay to pit generations against each other. We need family solutions to all of these needs. Ageism has a negative impact on your health. We know that through the data statistically. We all need to redefine aging by emphasizing that we are all aging, every single one of us in this moment. It's not they, it's us. Aging is the accumulation of experience and knowledge. It's a natural progression. And Linda Fried likes to say it's the only natural resource in this world that's expanding. So how do you take advantage of that? And I really hope you'll look at reframing aging and change the way you talk about older adults as people who are older adults. They don't like to be called greedy geezers or gray tsunamis or silver or senior. They're older adults. Next slide. So we're working on an age-friendly ecosystem with a group in Boston called the Age-Friendly Institute. And we're very, very excited about this work because what we know we need to do is create an ecosystem across all care settings. It was the World Health Organization that began really using the moniker age-friendly in 2006, age-friendly cities. And they have ways to measure and follow those cities. 2012, AARP in the United States began affiliations for age-friendly cities, communities, and states. In 2014, Frameworks Institute began studying public views of aging, and they did their reframing. And then in 2016, our foundation with the National Foray established the Ability and Disability Business Institute so that we could connect with community-based organizations. The Hartford Foundation, along with the Institute for Healthcare Improvement, introduced age-friendly health systems in 2016. I'm very proud to say that we're now in almost 2,800 systems of care in this country and 100% of every CVS Minute Clinic. So in 2017, we introduced our Trust for America's Health work, and we have been moving toward a global age-friendly ecosystem, and we're working with the World Health Organization with the person at the center so that cities, public health, employers, universities, and health systems all work together. Next slide. We want you to join us in creating an age-friendly world. And an age-friendly world means everybody of all ages. We need intergenerational and age-friendly approaches to improve society for all people, find common cause in family caregiving. And what we need that is critical for children is also for adults. We need to encourage healthcare providers to join the age-friendly health system movement. I'm checking to see if Michigan is one of them. I think you are. We've got a lot of activity going on with public health in Michigan, and very proud of that. We also want to encourage your public health department to be recognized as an age-friendly public health system. And you could do that through the agefriendlypublichealthsystem.org moniker. Please, please help us eliminate ageism by thinking about reframing aging.org. They just released a wonderful report called Reframing Nursing Homes. In all the press we saw during the pandemic talking about nursing homes as death traps, and then you hear a story about a hero nurse in a nursing home. Those two ends of the spectrum do not help us. We have to come together and say, we need a collective solution. We can do this together. The National Academy's report has given us a beautiful roadmap for what to do, what levers in Congress and state and local government, and what we must do in order to ensure quality of care in every setting. And certainly we owe it to our long-term care facilities and our older adults to get that quality and safety where it needs to be. I'd also like to remind us all that the eradication of family violence is essential to the well-being of our country. And that, again, coming back to the title that you've all created for this lecture, The Effects of the Pandemic on Trauma and Abuse, every one of us have suffered. I'm a nurse, my daughter's a nurse. I have seen exhaustion. And what we have to do is think about how to get our caregivers back in a place where they feel robust again. We need to work with our families to make sure they don't panic if you're afraid that we won't be there for them. We need to talk to our representatives and say to them, please understand that families are ecosystems themselves, and it's that continuation. I talked to a woman earlier today who was with us for a potential interview, and she talked about how her mother got sick and how that took her out of the workforce, and how that meant that her children were feeling neglected during that struggle to be the person doing it all. So I urge all of us to use this incredible moment to learn from one another, to work with one another, and to celebrate each other's successes. I know I'm grateful for the opportunity to speak with you, and deeply gratified that I could join you. And I want to turn it back to you all and thank you for including me today. Back to you.
Perfect. Thank you, Dr. Fulmer, so much for those very compelling remarks and that amazing framework that incorporates families as ecosystems, and how many incredible parallels there are across the ends of the lifespan. And I have many questions, but we'll hold those until a little bit later in our session. Thank you. Next, we'll move on to our three panelists, Deborah Cha, Todd Herrincole, and Preeti Milani. I'll introduce all three speakers, and then each of them will give a few remarks. Our first panelist, Professor Deborah Cha, directs the Pediatric Advocacy Clinic at the University of Michigan Law School and serves as the Associate Dean of Experiential Education. Her research, teaching, and legal practice focus primarily on education law, family law, domestic violence, and cross-cultural communication. She also provides regular trainings to medical providers on patient advocacy, special education, and social determinants of health. As the director of the Pediatric Advocacy Clinic, Professor Cha works with medical providers and law students to provide free legal services that address the social determinants of health of families and improve child health. Our second panelist, Todd Herrincole is the Marion Elizabeth Blue Professor of Children and Families at the University of Michigan School of Social Work. His scholarship focuses on the correlates and consequences of child maltreatment, risk and resiliency, and life course development. His funded studies and publications examine health risk behaviors in children exposed to adversity, protective factors that buffer against early risk exposure, and prevention. An internationally recognized scholar, Dr. Herrincole works with policy makers, school and child welfare professionals, and community partners to increase the visibility, application, and sustainability of evidence-based programs and practices in violence prevention, social emotional learning, and child trauma. Our third panelist, Preeti Malani, is the University of Michigan's Chief Health Officer and Professor of Medicine in the Division of Infectious Diseases. She's also the director of the University of Michigan's National Poll on Healthy Aging. Her clinical expertise includes both infectious diseases and geriatric medicine. She's had a longstanding interest in both the clinical and policy aspects of antimicrobial resistance, infection prevention, and infections in older adults. Prior to medical school, she completed a master's in journalism and continues to dabble in journalism. Her recent work has appeared in a variety of publications, including the New York Times, NPR, the Philadelphia Inquirer, Michigan Rivals, and the Health Affairs blog. I'd like to welcome all of our panelists onto the podium here with me. And I will turn it over to our first panelist, Deborah Cha, for some remarks.
Thank you. Thank you, Lisa. Thank you, Dr. Meister, and thank you, Dr. Fulmer, for your presentation. I am honored to be here. So Dr. Fulmer spoke about social determinants of health and the effect of unmet social needs on older adults. She identified 6 different priority areas to address the problems we will confront with our aging population. And she included remediating disparities and inequities, implementing new approaches to care delivery, and creating an adequately prepared workforce. And she noted, which was interesting, that healthy aging begins at birth. So you were all there, you all heard this, I don't need to recap anymore. But Dr. Fulmer's remarks and priority areas really resonate with me and the work that I do in the Pediatric Advocacy Clinic. The Pediatric Advocacy Clinic is a medical legal partnership between the University of Michigan Law School and healthcare providers at Michigan Medicine. So the Medical Legal Partnership, or MLP, is an innovative interdisciplinary approach to care delivery exactly along the lines of Dr. Fulmer's suggestions. The model integrates legal advocacy into the healthcare setting and thereby expands the definition and scope of healthcare. The goal of the MLP is to address social determinants of health, to provide free legal representation to low-income people, to address health-harming legal needs. So in the Pediatric Advocacy Clinic, we represent and we focus on pediatric patients and their families, but this approach to healthcare can really work for any population. When the Pediatric Advocacy Clinic provides direct free legal representation to address social determinants of health, we're not only helping the individual patient, we're reducing stress on all the adults in the family. And as we all know, the reduction of stress is positively correlated with long-term health and well-being. And honestly, this tends to be true whether or not we achieve perfect success. So we win many of our cases, but we do not win all of our cases. But families experience enormous relief at having someone by their side to navigate the legal system and to help them enforce their rights. So many of you are familiar with all the systems and laws that we have in place in America, which are designed to protect vulnerable populations. We have Medicaid to ensure healthcare access for low-income people. We have food assistance to ensure food access for low-income people. We have special education laws that are meant to provide educational access to children with disabilities. But many of these laws and their systems depend on individuals to enforce them. They do not necessarily operate effectively on their own, and not everyone is equipped to enforce their rights without help. So in the pediatric advocacy clinic specifically, we work on access to education, particularly special education. So this could mean making sure that a child's individualized education program, or IEP, is developed appropriately, making sure that IEP is being implemented with fidelity, and what we've been seeing more and more in my clinic is making sure that students with disabilities are accommodated within the school setting and not pushed out for challenging behaviors. This is directly connected to long-term health and future financial security. Another area we work in is ensuring Medicaid coverage for all of the healthcare needs of pediatric patients, especially when Medicaid managed care plans deny coverage illegally. We also work on housing cases to ensure access to safe housing that comports with federal and state housing law. And finally, we work in the family law realm and often are representing survivors of domestic violence in their efforts to obtain personal protection orders against abusers, and also custody of their children. So the inability to access education, Medicaid coverage, safe housing has negative consequences on the long-term health of everyone in the family unit. And the same, of course, goes for exposure to violence. And so what we're doing is partnering with healthcare providers to address these issues for individual patients and also systemically. This work, as you can imagine, is more important than ever in the wake of COVID and in the widespread trauma that the pandemic has caused, particularly for communities of color. We're seeing this in the country at large. We're seeing this in my clinic at the law school, the exacerbation of many of the usual problems, particularly around housing and education, again, both crucial social determinants of health. So I'll give you an example. We have been working extremely closely with pediatricians and especially behavioral health pediatricians, some of whom are here today, to identify students who need extra advocacy in the special education context, again, particularly around school discipline. These children should be accommodated within the school setting. Their behaviors should be addressed within the school setting, and almost always they should not be excluded from school. Individual advocacy helps inform systemic advocacy. As we identify children who need individual help, we're keeping data on different cases or different problems that are arising in different schools and across particular school districts, so we can make a plan for targeted systemic change, whether that's through educational interventions or filing systemic complaints through the law school. If we are going to set families up for long-term health and stability, we need to be able to address the social conditions that have a negative effect on long-term health and stability. And so working through a medical legal partnership is exactly the kind of approach that has the power to make a difference for families and communities. Thank you.
Okay, I'll follow Deborah. Thanks so much for allowing me to say a few remarks. I'll build on Dr. Fulmer's comments and Deborah Cha's comments and remarks by speaking a bit about children's well-being before and during the pandemic. And then I'll end with some thoughts about how we can respond better to the needs of vulnerable children and families. So let's begin pre-pandemic and the challenges that existed then. Prior to the pandemic, young people were experiencing a range of issues. Rising concerns about violence and safety in schools, as Deborah mentioned, high levels of disengagement, disconnection from school, particularly among adolescents or high school students. Online bullying and peer harassment was getting some attention. We also observed rising levels of emotional and mental health conditions, particularly anxiety and depression. According to a report by the CDC using their youth risk behavior surveillance data for 2009 to 2019, more than 1 in 3 high school students said that they had experienced persistent feelings of sadness and hopelessness. Data also showed a rise in self-reported suicidal behaviors from 2009 to 2019, possibly linked to depression. We were at the same time experiencing a national opioid crisis, exposing children to substance use in the family, death and loss within some families as well. And there was also increasing concern pre-pandemic about the prevalence of adverse childhood experiences. And these include various forms of child abuse and neglect, problems in the household, including drug and alcohol use and mental illness. And they're of particular concern because they're thought to have long-term mental health and health-related consequences for those who've been exposed. According to some other CDC data, actually over 60% of adults recall having been exposed to at least one adverse childhood experience in their lifetime. And about 1 in 6 adults, about 15%, recall 4 or more ACE exposures during their lives as well. Of course, when we look at ACEs, we have to be mindful, actually, of the very evident persistent gender and racial disparities in exposure that exist, as well as the associated outcomes related to well-being and life expectancy. So this leads us back to a conversation that Dr. Fulmer began, actually, about social determinants, and Deborah alluded to as well, and the ways in which conditions in the social environment impact child development. So both prior presenters spoke about social determinants, so I won't spend a great deal of time on them per se, but I would like to show a figure, and just put up the next slide, that connects some of the more common forms of diversity that we see in children around, again, emotional sexual abuse, physical emotional neglect, divorce, mental illness. What this figure does quite nicely, I think, is show how they're very rooted in the disparities and social determinants, right, that we know to be so significant. So poverty and discrimination, community disruption, lack of opportunity, poor housing, all playing a significant role in the incidence and prevalence of ACEs across different segments of the population. So with the onset of the COVID-19 pandemic, challenges facing young people became even more pronounced. So social distancing and stay-at-home policies quickly led to school closures and major disruptions in social life, causing for some significant social isolation and adding to the pre-pandemic experiences for teenagers of disconnection and disengagement. During the pandemic, young people have experienced caregiver stress, rising levels of psychological distress, fear, concern, worry, depression, anxiety, suicidal ideation, health concerns and illness, experiences of death and loss, unfortunately. And not surprisingly, pre-existing vulnerabilities have led to more susceptibility among some, particularly among racial and ethnic minorities and marginalized youth populations, youth with disabilities, LGBTQ plus youth being among them. This next figure illustrates this pattern nicely. I hope that you all can see it on the screen here. Basically, this is showing that social disruptions during the pandemic influence or are thought to influence child well-being both indirectly and directly through the effects on the family system, on caregiver well-being. And here again, this figure shows how the role of pre-existing family vulnerabilities and increasing the risk among certain segments of the population more than others. To this point, this next slide, Angela, if you go to the next one, illustrates clearly how certain groups have suffered more. So this is a study published by Hills and colleagues in 2021, so it's a bit dated at this point, unfortunately. But the data are from the National Center for Health Statistics and show that we had 140,000 children under the age of 18 experience death of a parent or a grandparent in a primary or secondary caregiver role at that time. Yet the risk of loss was 1.1 to 4 times higher among racial and ethnic minorities, Hispanic and Black children in particular. Children of racial and ethnic minorities account for 65%, about 2/3 of those who lost primary caregivers, but only 39%, or 40% of the total population. So to finish up, I'll just echo some of the points actually that Dr. Fulmer and Deborah Cha already introduced, and I'll refer very specifically to some recommendations around child health and thinking about ways to better support children in need. The first thing I think that we need to do, and foremost, is to acknowledge that there are very evident inequities and susceptibilities, differences in risk that exist within the population. We also need to acknowledge that systems of care for children and adults, for that matter, are poorly equipped to do much about these inequities in their current state. That we're in desperate need of child-serving systems that focus on prevention and early intervention. We know that the best solution to these problems are getting ahead of the issues and intervening early, and that we need to do more to increase collaboration and communication across systems of care. Lastly, we need to look at ways to engage, empower, and resource communities so that they can do a better job of supporting families at a local level. I think that that's something that Dr. Fulmer also underscored in her remarks. So with that, I'll stop and hand it over to Dr. Milan.
Thank you, Todd. This has been such a thoughtful and inspiring conversation. I just wanted to, first of all, thank Susan Meister for your commitment to improving the lives of children and families. And of course, to my friend Terry Fulmer, also for your deep advocacy of people of all ages, but particularly older adults. And I'm so grateful to be part of this conversation today. And alongside Deborah and Todd, I mean, really talk about moving across disciplines. This has been really, really interesting because so many of the themes resonate with me, both in my clinical world and in my research world. And you know, the pandemic has just been an extraordinarily difficult time. And we've spent, gosh, almost 2.5 years now really talking about COVID every day, all day. And even though I'm an infectious disease doctor by day, one of the things I say is that COVID and infection is not the only risk to our health. And it's the non-infectious disease related health issues, whether it's delayed care around the mental and emotional well-being issues that we just heard about, that are really concerning to me. And, you know, my professional worlds really span the age spectrum, really from young adults who, you know, we could call them older children, if you will, you know, our students on campus, all the way to older adults. And, you know, for somewhat different reasons, the pandemic has been really challenging to both of these groups and to families, and frankly, to anyone who is a caregiver more broadly. I think it's simply been just unimaginably difficult, particularly for families. And for the past 5 years, I've had the honor of serving as the University of Michigan's Chief Health Officer. And it's a little bit of a different role. And I serve as a key advisor to the president and other executive officers on really all aspects of health and well-being. So students, faculty, staff, and really taking a very broad view on health. And as far as campus goes, I'm one of several people who's really been involved with trying to navigate really an impossible situation, you know, this idea of a global pandemic on a college campus, and to continue the university's essential work. And you know, back in March of 2020, when I think back to that time, it feels like a lifetime ago, but within a matter of days, Michigan, as well as every other school, K through 12, as well as university, college, basically made an unplanned, largely unexpected, rapid pivot to remote learning. And at that moment, it was like flipping a switch off, turning off the lights, shutting the doors, and really getting everyone home who could get home. And the public health issues were the only things that mattered. They were the only consideration. And there were numerous concerns about equity and overall well-being. And, you know, when I think about the college students, for example, depression, anxiety were already at epidemic levels, and the idea of isolation on top of that, what was going to happen with that. And of course, we had many students on our campus and across the country who couldn't learn remotely. They couldn't really continue their education if they went home. You know, maybe going home meant no Wi-Fi access, including rural communities without broadband. Others would have been caring for siblings, you know, working to support their family's basic needs. But staying here meant being all alone, literally being in a room by yourself. But at that moment, COVID drove all the decision makings. And, you know, now it's really on campus anyway, it's really doubling down on the emotional well-being issues and the academic issues. We're no longer talking about preventing every case of COVID. We're talking about protecting high-risk individuals and preventing large outbreaks, preventing disruption. And I'm glad that some of the focus on our campus is really shifting to talking about emotional well-being. And I will say, as a parent, I'm very worried about academics. I think the last couple of years, there hasn't necessarily been the same degree of learning that's going on. And I often also say that I can manage COVID with vaccination and other prevention measures, but that's not true of a lot of other risks to our health. And of course, we should also talk about older adults, and older adults have been deeply affected by the pandemic. And again, Dr. Fulmer reminded us, the US pandemic very early on, it was epidemiologically linked to nursing homes, especially in the Northwest in Washington State. And many community dwelling older adults, including my parents and my in-laws, they simply had to take themselves out of circulation. We didn't really understand a lot of things about the virus, but not only did they take themselves away from families and friends and jobs, but away from other meaningful social interaction, away from exercise. People were putting their groceries and mail in the garage waiting to be disinfected. And I think, thankfully, we have forgotten that because it feels like a long time ago, but some of those ill effects from that isolation and that lack of movement and other things really is continuing to have effects now. And for me, those images of family members really being locked out of whether it's an assisted living or a nursing home, and sort of sitting looking in windows is something that will always stay with me and always really frankly haunt me. And I don't think I'll ever forget that. And in 2020, the most common call I got from friends was, I need to go see my parents. Tell me how to do it as safely as possible. And I think we would create these elaborate systems and to bubble and make things as safe as possible. And if people didn't get COVID, they had other ill effects happen. And some of these things, the loneliness, social isolation, falls. These are things that were looked at with the National Poll on Healthy Aging. And I just want to take a few minutes to talk about that. And maybe we can share the link, healthyagingpoll.org. And the National Poll on Healthy Aging really grew out of this desire to understand the day-to-day lives and experiences of older adults in the US. And for purposes of this poll, we're really interested in 50 to 80. So not just aging, but pre-aging. And this was modeled after the Child Health Poll, which I know our audience today is very familiar with. This is a recurring nationally representative household survey of US adults on issues related to health, healthcare, health policy, and really all the things that affect our lives. And we use the term health very broadly. And our goal has always been to move beyond the sort of the traditional medical issues and really get at aspects of social well-being. And when the pandemic began to unfold and it really became clear that this was not a short-term thing, we really as a team decided to try and capture that moment and some of the effects on the pandemic. And again, you can look at those reports, but I just wanted to share a couple highlights. And these are themes that were mentioned today. In June of 2020, we asked about loneliness and social isolation, so lack of companionship. And this was a follow-up to a similar poll that was done in 2018. And what we saw was a substantial increase in loneliness and isolation among older adults during that, especially the early phase of the pandemic, March to June of 2020. 41% reported that they lack companionship, and that was up from 34% in 2018. And this was a measure of loneliness. And 56% said they sometimes or often felt isolated from others. And this was more than double the 27% who felt that way in 2018. And again, not surprising because of what had to be done at that moment, but that was every bit as important as trying to prevent viral transmission. And technology did bridge some of the gaps for some older adults, but not everyone had access. Another issue addressed by a more recent poll is on disrupted care. And I think this is something that I am seeing in my practice and other people are also seeing with older adults. Many of them had appointments to see doctors, see dentists, to have a procedure done, cancer screenings, and the pandemic really disrupted a lot of those. And about 30% of older adults reported that they had a scheduled appointment canceled, either by themselves or by their providers. And we didn't ask about 2020, but I'm sure the number was even higher. And we're still seeing the ill effects from that. And mental health was another topic that was explored. And the COVID-19 pandemic has really not been good for anyone's mental health. It's been terrible, whether that's children or adolescents, younger adults, older adults. But the issues of isolation, loneliness, not being able to engage in meaningful activities has really, really affected people's well-being. And when we asked in January 2021, so about a year into this, 50 to 80-year-olds about their mental health, they commonly reported symptoms of depression, anxiety, trouble sleeping, and 28% reported that their mental health was worse in terms of anxiety and worry. 19% had worse sleep. 19% had worse depression. So, again, as a group, the older adults were probably doing better at baseline than a lot of our younger adults. But that emotional well-being piece is something that was very, very important. And just the last topic, falls. More than a third of people between the ages of 50 to 80 reported that their physical activity had declined. Now, some people were actually more active, but that was the minority. And more than a quarter said they were in worse physical condition than before the pandemic. And many had an increased fear of falling. And as you may know, if you worry about falling, you may not move around as well. And, it leads to actually a higher risk of falling. And in fact, 25% of older adults experienced a fall from the start of the pandemic until January 2021, when the poll was conducted. And 40% of those had experienced more than one fall. So I think as things have improved from a public health standpoint, everyone is starting to really think ahead and re-engaging. I hope we can work together and use this time to really think about health and well-being in a broader manner, in a population-based manner, both for children, younger adults, and older adults.
Terrific. Thank you. Well, thank you all for sharing those incredible insights from your unique perspectives. And even so, there were many similar themes across all of your areas of expertise in hearing about challenges for both the very young and the very old. That these were all challenges and issues that existed prior to the pandemic, but really exacerbated by the pandemic. And so the pandemic has shined a light and potentially given us an opportunity to really address and tackle some of these challenges that have been around for a very long time. So thank you all for those comments. At this point, we'll open it up for a Q&A. And to those of you that are joining via webinar, please feel free to submit questions through the Q&A section. We do have a number of questions that were submitted ahead of time, and I'll start with one for Dr. Fulmer. So Dr. Fulmer, you noted that intergenerational age-friendly approaches improve society for all. Can you expand on that idea and explain how?
Yes, thank you. And I want to just commend all the other panelists. Those were really important presentations, and I learned a lot. I knew Maggie Kuhn. Who on this panel knows Maggie Kuhn? So Maggie Kuhn founded the Grey Panthers, and the Grey Panthers were founded in Philadelphia. And the premise was intergenerational living would benefit the world. She was right. That was probably in the 60s when the Grey Panthers were beginning to become their most vociferous, and I'll always remember having the privilege of meeting her. I think that there are themes, and I worked with Eli Neuberger at Harvard when I was there, and he had a center on family violence. And I think that probably if we could think about the ways in which our family system work, and I know you all do that, could accelerate our understanding of how to improve the lives and well-being of families, particularly those who are disadvantaged, that we would make a lot of progress. And I know there are intergenerational researchers doing just that, but I think we could do even more to connect our work together. So why don't I turn it back to you, Lisa?
Okay, terrific. Thank you very much. Would any of the other panelists like to comment on that question? Okay, I'm going to move on to another question for Professor Cha. Can you speak to the potential areas for greatest impact on social determinants of health using the medical legal partnership model?
Absolutely, thank you. So when medical providers and legal services providers are really connected to one another, and when they're sharing information freely, there's enormous opportunity to affect positive change, because we can identify social determinants of health in the lives of all these low-income families and work to address them. So I have too many examples to give, but I'll give a couple. Just recently, a pediatrician who we've worked with over many, many years referred a family, a single mother with multiple children who has an extreme rodent infestation in her home. It is exacerbating asthma and allergies in her children and in herself. She told me on the phone today she cannot breathe in her house. And so they have become homeless, essentially. So by referring that family to the pediatric advocacy clinic, we can then engage in some advocacy on behalf of the family with their landlord. And again, like, individual advocacy opens up opportunities for systemic advocacy as well, because if we start to see multiple problems with the same landlord, we can get more people together and put more pressure on that landlord. I'll give another example of systemic advocacy. We've been working with the complex care management program for a long time, and an issue that they've identified as being problematic is Medicaid is supposed to cover transportation for patients to get to their healthcare appointments. And in many, many cases, the transportation either does not arrive or does not arrive equipped to transport that particular patient. Maybe the patient is in a wheelchair and the cab that they send cannot accommodate a wheelchair. So by being really connected, by sharing information, the clinic can take individual cases and push individually, but we can also take a step back and think about how can we affect systemic change and in what ways. So I would say when we are really connected, there's infinite potential.
Great, thank you. And that really speaks to the theme of our discussion today, is that working across disciplines is really crucially important for making change and really helping children and their families in this space. Dr. Herrenkahl, what are some of the more promising approaches to prevent and mitigate risk for abuse of children? And I think, and this is a question too, if other panelists would like to comment afterwards as well.
Yeah, so maybe I'll kind of circle back to a comment I made in my remarks earlier about kind of how poorly equipped systems are currently. I think primarily the child welfare system as primarily a reactive system, like that does not engage in prevention and early intervention supports of families, and the consequence of that is that families are connected to the system way too late in the process, and the issues that they're experiencing that have to be very resistant to change. And so a lot of the work that I do is really kind of speaking about the need for universal and blended prevention strategies, so we're kind of getting upstream and working with policymakers and program developers to really think about what that looks like. Economic supports, parenting programs, home visitation programs for young families are another critical elements of that sort of new way of engaging. But the early intervention, primary prevention kinds of strategies, I think, are really critical.
Terrific, thank you. Would anyone else like to comment on that question? Okay, I have a question, Dr. Milani, for you that I think others will be interested in commenting on as well. But from your various roles, you working with individuals at both ends of the lifespan, what have we learned during the pandemic that can be applied to health in general as we move forward?
Thanks, Lisa. I would say I think we've learned a lot. One of it is this. One thing is that people who normally haven't spoken to each other or met each other, they're together every day. And so on our campus, for example, I'm actually hopeful that some of that energy will continue. But really, more than anything, I'd say the pandemic has been a very powerful illustration of just how big the gaps are in equity and justice. And this example that Deborah just shared around the rodent infestation, that you could treat asthma all day, and unless you take care of the rodent problem, it doesn't matter. So that idea of public health being central, and I know that that's something that resonates with you as a public health person, and probably to many of people in the audience. But when we think about equity as a way to really improve health and well-being and do it in a multidisciplinary way, I think we can really leverage some of that public health infrastructure that has been built. and really those relationships that have been built, whether it's in the clinical realm or in like K through 12 schools or higher ed, or in communities like to help care for older adults. I'm hopeful that there will be something really good that comes out of some of all this pain in terms of just addressing other pressing health concerns. Can we put that same intention toward that?
Terrific, thank you. And others, would anyone else like to comment on that as well? Dr. Fulmer. Okay.
I'm happy to comment for.
Comment, go ahead, great, terrific.
I just want to echo what Dr. Maloney said. The more we can get people into the same room, like a giant light has been shown on these inequities and disparities between communities. And there's so many of us who care deeply about these issues, and we're working in our own separate realms. And the more we can get people together to think really creatively and openly about solutions, like in a forum exactly like this, and then in much smaller settings too, there's just so much opportunity to address, to create change. One of my favorite activities that I do with my law students is we engage in case rounds where a team of law students will present an issue that they're struggling with in one of their cases to our class, to our little seminar class at the law school. But I often invite in pediatricians, social workers to be part of the conversation, and the conversations are so much richer. We generate so many more solutions when we have people with different training and different backgrounds and different problem-solving approaches come together. So I think, you know, the pandemic really like marshaled all this energy in the world to address this problem. We need to bring that same energy to these other problems that are acute.
Great, that's a terrific example. Thanks for sharing that. Any other thoughts about that question? Or we have a number that have come in on the chat here. So I'm going to move on to a question from Mark Zimmerman, who's asking, can the speakers talk about some of the positive aspects of life? And this touches on a few comments that have just come up, positive aspects of life that have happened as a result of the pandemic, and maybe something about those factors that may help people across the lifespan overcome the negative consequences of the pandemic.
I can just chime in that, again, going back to the poll, and again, I hope people will look at the website, but we actually asked about this, joys and stresses, and that again, this has been catastrophic. I don't want to say that this has been, you know, silver linings and things. I think that, but there have been opportunities, and I think individually people have sought joy and found joy, and whether it was, you know, getting a pandemic pet, or it was getting to know your neighbors, or it was learning to cook, or, you know, in the case of my family, we got a little bonus time with our young adult children because they were home. And so I think that there have been joys for people, and, you know, maybe people have looked for that joy. And, you know, in the older adults, it's the things that you might think of, you know, it was like spending time with friends and families, and, you know, doing things that are meaningful. And maybe at the fact that vaccines came and people like started getting back to things that really mattered to them. And I know there was much joy in my family when that happened.
Right. Terrific. Thank
you.
you.
I love those. And you expressed that so beautifully. I'd also add that we learned a lot about telehealth and behavioral health via telehealth, and how it can be done. You know, we were able to use telehealth for behavioral health across state borders. I hope that stays. I think it's already pulling back, and that's a problem because not all states, not all communities have the same access. So the telehealth, and we've also needed to be strategic about the use of technology in other ways as well. So I think that has accelerated something positive. The other thing is the real recognition of family caregivers. They're not visitors when they come to a nursing home. They are part of the care team. Turns out that if you were to calculate the number of hours they spend, it's at least a shift a month doing the work, being the eyes and ears, for those older people and in the home. So I think that, and in the hospital where none of them were. So I think that just recognizing the extraordinary work of family caregivers, and that goes for all age groups. But of course, I'm focusing on older adults for the purposes of my remarks today.
Great, terrific, thank you.
Mhm.
Any other thoughts about health? And we can come back to this as well. Feel free to turn back to earlier questions. I am going to go to another question that's coming through the chat. Bear with me. It's a little bit long, but I think makes a really important point. This question asks, so many child welfare organizations are reporting that child abuse and neglect cases did not increase during the pandemic. Those within the field of child welfare are aware of the great stress families were under. They hypothesize that the lack of increase was likely due to children having less exposure to mandated reporters, schools, child care facilities, and other mandated reporters. A recent article in US News cited a report presented at the meeting of the American Academy of Pediatrics that the number of children seen in emergency rooms over a 9-month period in 2020 for child abuse-related injury tripled. And sidebar, I mean, that's similar to the some of the data that Todd shared with us. As such a very small percentage of children who are abused or neglected are seen in emergency rooms, this study raises serious concerns about the amount of abuse that went unreported and what we might anticipate moving forward. And so the question is to the panelists, could you share your thinking on this concern?
I would say that happened. Go ahead, Todd.
No, go ahead, Terry, go ahead.
Simply to say that that was universal across age groups, whether you were a woman with an abusive relationship or an older adult or a frail elderly person. It was universal. You go behind closed doors, you have no longer the gatekeepers that we so rely on in our society to maintain some of the things that are just basic. Back to you, Todd.
Yeah, I was just going to say that I mean, and the really kind of unfortunate thing is that only the most severe, forms of abuse make their way into emergency departments. And so, I mean, clearly there is an issue around underreporting, and I think, Terry, to your point, that not having those gatekeepers, not having the people on the front lines who are able to detect when things are happening is a real concern. On the other hand, there's also, I think, a tendency, particularly among people who work in certain settings, to probably report a bit too quickly sometimes. And a lot of the cases that come to the attention of child welfare, to the child welfare system are screened out because they don't, sort of meet the threshold for abuse and neglect. But going forward, I think what it underscores is that we need to do a better job of detecting things that go under the radar.
Yeah.
We know, all of us who work in this field know that the large proportion of cases never make their way to to the authorities, and they're never investigated, and kids suffer as a result. So hopefully it will prompt us to get a little bit more creative, I guess, in our thinking about ways to see at these the early signs of abuse and neglect. And it's not just physical abuse. I mean, there are lots of other things that are happening in families, as I think Terry alluded to earlier, that we need to know more about.
Mm-hmm. Thank you. Any other comments on that important question? Well, I think it speaks to kind of how much, as all of you have already mentioned, we're just starting to see data coming out of the pandemic and what we may be seeing kind of moving forward. I have another question that's come in specific to orphan children. And Todd, you mentioned this a little bit in your remarks. And so the question around this vulnerable population who've been orphaned during the pandemic, it's an issue that's being deeply grappled with on the policy side. And so to all of the panelists, what would be your recommendations for dealing with childhood grief and loss of parents, dislocations from their home, resettlement in relatives or friends' homes, or even a move into a public system of care for orphan children? So any thoughts or discussion on those points?
I'll say just real briefly, and I'm sure other people have thoughts on this too. I mean, for me, the most critical thing is creating communities of care. Whether we're talking about literally, communities, or we're talking about school settings, we're talking about other places where kids spend a lot of time, having adults care about them, having friendships with peers, right, who are have a positive influence, feeling safe in their surroundings and feeling nurtured and cared for. Those are the things that allow kids to heal. And to the extent that we can create those places, and Deborah, I think the work that you're doing is serving that purpose in many ways, is so absolutely critical. So I put a lot of time and energy into thinking about how to create schools that are, safe, nurturing, and inclusive. And with the very goal of creating the opportunities for kids who've experienced trauma to benefit, right, from the relationships that come from that. So that would be my general response. I think the more we can create communities of care, the better off children will be.
Great.
I think a great example of that caring community is the YMCA nationally. And when we do work with the YMCA, we work with them on their diabetes prevention program. But during the pandemic, we called them, and we know that 100% of YMCAs had to close. And that was extraordinarily devastating to their revenue, but also they had so many people depending on them, children who do after school programs, older people who are doing their silver sneakers and exercise programs. And what we did was we funded the Y to do a special report for us on what they learned during the pandemic related to the older adults they were serving. And they were doing virtual swim lessons with older adults who were used to their swimming, and they said, okay, we're going to do this. And they converted so much to Zoom. They were so creative. And I just want to remark on my profound admiration to the YMCA and YMCAs in this country. There are other organizations like 4-H clubs and all different kinds of community. Those are so vital. Our libraries are places where people can observe and participate and see if something is maybe not going quite right. Or see, for example, if somebody's in the library, suppose an older person starts losing their memory. You have these natural pools of people if we look out for each other. And sometimes we do, and there's a great report. Marcus just, thank you, Marcus, for type that in for us. Marcus Escobedo is our Vice President for Communications. And to just look at those logical places, as Todd just said, the schools, but also the Ys, the playground associations. So I've just seen a lot of creativity and passion during this time in those spaces.
I'll just also add, in thinking about schools and how they're dealing with grieving children, there's bound to be, and we know that there has been, a lot of disciplinary problems. Like, we're going to see a lot of behavioral problems for kids who have suffered trauma. And so we have all these children in school who have just suffered the trauma of social isolation, and not being physically present in school, and educational neglect. I mean, not from the families, but because everything was shut down. And then to put losing parents on top of that, schools are going to have to be extremely compassionate towards these children and not use exclusionary discipline to address the behavior problems, because we know there's been an uptick in behavior problems, and we're just seeing so many kids suspended or expelled, and it's going to compound the problem. And schools also have to be really compassionate to the caregivers who've had to take over, like grandparents who are taking over the care of minor children. They might not be as adept in the modes of communication that the parents would have been in to communicate with the school. So, I mean, I know there's an enormous burden on schools, but they're also going to have to rise to the challenge. And
I would add, and Preeti was talking about this earlier, college students. They're one small group of people in that age band, reminding us that only 30% of college students in this country graduate. So I think that there's an organization in Boston called the Mary Christie Institute that has accelerated their very excellent work. I am on the board. Their very excellent work in mental health in college students. And there we see the same behavior problems, the addiction and substance abuse going on that is accelerated from where it was, violence and just behavior you wouldn't have anticipated prior. Preeti, have you seen that in your campus reports around the country?
The the mental health issues were there, and they were like astronomical.
Yep.
And they're just at a whole different level of the distress. And I think it's not just the students, it's their families, it's the faculty, it's the staff who are supporting them. And I think again, that social connectedness, which we all, which I think does bring us joy. I mean, even the way we're doing this talk today, which actually has worked quite well. I feel like I'm in the room with all of you, but it's just not the same, right? And so I think we're starting to really think about, okay, we'll do this around managing infections, but what are we going to do to really help people feel like they belong? And I think that's the term I like to use, like belonging, and how much value that brings. And I think people are bringing a lot of grief, whether it's from a death in their family or a loved one, but grief for other things that are lost. And I think those younger kids are going to come up through the system, and the entering students this fall who did their junior year virtually.
Yeah.
There are going to be a lot of challenges. So yes.
I think fundamentally our country tolerates violence.
Yeah.
And until that changes, we're going to have a lot of work to do.
I think on that last question, I think we'll move towards the end of the panel. I would like to open it up if any of the panelists would like to make any concluding remarks, listening to the discussion, reflecting on any of the other panelists' comments. I would also like to just share with the audience that there are a number of other questions that have come in that have asked very specifically for resources around addressing for educators, and we'll try to pull together some of those based on comments from the discussion today, as well as others from our panelists. Some have also asked for areas where they can volunteer, and we'll be happy to share some of that information as well afterwards. So let me pause here. Would anyone like to share some concluding thoughts before we wrap up for the day?
I might just say that I love that we talked about ageism and IEPs in the same same discussion, and I hope that is the view we have, that we all sort of share knowledge, and that we work together, and that we do move forward in a very multidisciplinary world. And I know many people who are attending today are, and it's amazing like how many people, like even the people on the panel today who I didn't know the work that they do, but I'm like looking forward to talking to them. So I hope that is one thing, if we can scale that, we could probably do a lot of really amazing things.
Great. Perfect, thanks.
I just wanted to echo that too. Like this, when we talk about moments of joy, these are moments of joy, like sharing ideas, sharing passions, and think it like sparks motivation to work together in the future. So thank you for convening us. It was really wonderful.
Great. Well, thank you for joining.
And I'll just piggyback on that as well, and just say, I'm thinking about Mark Zimmerman's earlier question about like what has come from this that's positive, and I actually think for me it's an awareness that continue. Deborah, I think you said this earlier, so I'm just kind of underscoring something maybe you said, that to continue to work in the way that we have is not going to work. This something like a crisis of this magnitude has only convinced me more that we really need to rethink the way we operate at at a research level, at a practice level, a policy level. So hopefully, we'll all get on board with that message and do something different.
And I feel like we've all bonded during this conversation because we have so many shared interests and passions. And I'm so grateful to have been able to participate with you today. When I first when Susan called me, I said to her, you know, when you're talking about a lecture in child health policy, I'm not sure what I could add, but I feel like all of us have educated one another today. So thank you.
Well, thank you. And I just want to thank all of you for joining today. Professor Chop, Dr. Herrenkohl, Dr. Milani, especially Dr. Fulmer for joining. That there have been so many common themes, so many challenges at both ends of the lifespan, but so much opportunity that has been raised during the conversation today about ways to partner and move forward, especially with a focus on community, families, how we can create a sense of belonging, and that all of these will require the hard interdisciplinary work that we all love to do. In working, although the title of this lecture is Child Health Policy, it's all of the challenges that have been discussed today are far beyond health policy and will require working across sectors to create policies together to really create an impact in all of these areas. So again, I want to thank all of you and really appreciate it. And Dr. Fulmer, I just wanted to share that usually I would present this in person. Angela, if you could just share the slide briefly. We have a small gift in honor of your joining us as our keynote speaker. I'm not able to give this to you in person, but we have sent it to you. And thank you again for joining as our keynote. Again, thank you so much to everyone for joining today. Thanks for all of the wonderful questions from our audience both today and beforehand. And again, we'll look forward to following up so that we hope to be able to engage everyone who is here today going forward. Thank you again, and hope everyone has a wonderful evening. Bye-bye.
Thank you.
Thank you.